Excellent question. Thank you for this. I'll start with the last part of the question. So why is it important to treat NASH now? So first of all, if you look at the epidemiologic aspect and the impact that this has on the healthcare resources, we know this is an epidemic, right? We can call it a NASH tsunami if you want, because this is really paralleling the increase in the epidemic of obesity and type 2 diabetes. So we know about a third of patients worldwide have fatty liver or NAFLD. However, if you just take patients with diabetes, this number becomes significantly higher. In fact, 7 out of 10 patients, or 60 to 70% of patients with type 2 diabetes, will have a fatty liver or NAFLD. And if you look at the more advanced disease form of NAFLD, which we call non-alcoholic steatohepatitis, which is the one that can progress further to liver cirrhosis and is associated with more cardiovascular disease as well. Although the prevalence worldwide is perhaps in the range of 3 to 7%, in those with type 2 diabetes is 1 in 3 patients. So, and again, those patients are more at risk for progression. So, in a screening study we did here at the University of Florida, the prevalence of advanced fibrosis, or really those patients at risk for progression in type 2 diabetes, is 1 in 5. So, for me as an endocrinologist seeing these patients in clinic, it's a very important message to, get across to other endocrinologists and primary care who are seeing these patients in practice, that if you are not screening for NAFLD with advanced fibrosis, you're probably missing 1 in 5 out of these patients that you're seeing on a daily basis. So in addition, if you have non-alcoholic fatty liver disease, you are set up to a higher risk of developing diabetes, about twice as higher compared to those without NAFLD. And in addition, there is an increased risk of cardiovascular disease. And to emphasize this important aspect, we publish current guidelines, including the ones from the American Association of Clinical Endocrinologists and the ASLD guidelines that are coming up very soon, to emphasize these connections and important aspects. In addition, American Heart Association recently came up with a white paper emphasizing the association with cardiovascular disease. And of course, because of this increased risk and prevalence, NASH and NAFLD is getting up there in the top for liver transplantation. So I think these are all important reasons why it's important to treat now. And to get to the first part of your question regarding, why we have to remember that we have available tools now. And we do. You are very correct about that. We have tools that involve not only patient and physician provider education, but we have many tools to promote strategies to improve NAFLD, including meaningful weight loss, not only lifestyle intervention, bariatric surgery, but also pharmacotherapy. And importantly, to have a multidisciplinary approach to treating NAFLD and individualized treatment. So, in my practice, since I'm an endocrinologist and I see a lot of the patients with have obesity and type 2 diabetes. So as I mentioned, this is a very high risk population for NAFLD and, NASH, about a third of them. So I do focus on, again, the tools that we have, and mainly weight management, since the majority of these patients have overweight or obesity. So from a drug perspective, however, in addition to lifestyle intervention and use your dietitian and a multidisciplinary approach, I like to use combination treatment known to be effective in not only weight loss, but also improving insulin sensitivity. For example, drugs like TZDs as well. And I also use obesity medication or anti-obesity medication, including phentermine alone or in combination with topiramate and others, to, again, promote meaningful weight loss, which is probably important to mention here, in the range of 10% is what we want to achieve in these patients. as this has been shown to be associated with improvement in all of the aspects of steatohepatitis. So not only steatosis, but also inflammation and fibrosis prevention or improvement. So what I do in clinical practice, and I think it's probably has become common practice in endocrinology and primary care, although perhaps in hepatology practice it's coming as well, is adding or starting a GLP-1 as a first line for treating weight and obesity, in addition to addressing cardiovascular disease aspect, prevention of atherosclerosis. This approach will also improve insulin sensitivity, treat glucose control, and will treat NAFLD. So I use, as I mentioned, the combination treatments, including GLP-1 as a first line, low-dose pioglitazone, and combination with SGLT2's inhibitor as well. I think we are still behind here, and I think that's where we have to catch up, and that's where the guidelines, the role is to emphasize this important connection and the fact that we have available tools now. I cannot really speak for all hepatology practice worldwide. I know some hepatology practice are more comfortable than others using these agents. Others are, again, using this in combination with your endocrinologist, your friendly endocrinologist and primary care. So I see the treatment of NAFLD and NASH as arising early on, and that has to take care in the primary care endocrinology setting, to prevent progression further and to reduce the number of patients who may end up needing a referral to hepatologist or needing a liver biopsy. So I think, I think with the current guidelines emphasizing these tools and emphasizing the role of the GLP-1 receptor agonist and TZDs as a first-line treatment for these patients, especially those who have biopsy-proven NASH, I think this will start picking up and, will become common practice. So in clinical practice, really, we've been using this for a long time now, but in clinical practice, it's really not that difficult to use GLP-1 receptor agonists. Certainly, there is a certain barrier because the majority of them are injectable, and some patients may not like this idea. But as long as you educate a patient, over the benefit, and you say, you have an important disease that we want to prevent and treat, and emphasize the benefits of these drugs that are multiple, not only treating glucose, weight, but also improving cardiovascular outcomes, which is a general class effect for this drug. I think with that, you can get the message across, and I see many of the patients being willing to embark in this treatment. In terms of how to start, I always start at the lowest dose and titrate as tolerated, per guidelines or indications. We like to maintain the highest tolerable dose to achieve the weight loss goal. As I mentioned, important to achieve that goal of at least 10%, but I've had experience with patients achieving much higher percentage of weight loss, 20 to 25%, which is very impressive. Again, it's very much individualized, like anywhere in weight loss medicine. I counsel about the side effects, especially the GI side effects, which are common, and they tend to become more common with higher doses. I tell them that majority are experience these side effects, but they are most commonly non-serious. And I also counsel on the importance to maintain the treatment, as the patient has to be aware that if you stop the treatment you initiated, chances are significant weight regain will occur and losing the benefits we have achieved. I also avoid, of course, in patients who have major contraindications, like severe diabetic gastroparesis, significant gallbladder disease, as these agents can exacerbate or precipitate gallbladder disease through the weight loss and other mechanisms. And I try to avoid in those with decompensated cirrhosis. But other than that, I use it very widely. And, with these guidelines, and if you counsel upfront the patients, this is a path to success. And what I see from my patients is, is very rewarding to see them back and see that they are doing well and they are actually feeling better and have significantly improvement in their symptoms. And regarding that, actually, it's important to mention that a lot of us are referring to NAFLD as an asymptomatic disease, but there is actually evidence recently to show that some of these patients do have some symptoms that seem to be related to the disease, and this is significantly improved once you treat and you achieve the weight loss goal. I think, as we started, it's important for everyone to know that we have these tools available. I think it's important to get across that most likely, like diabetes, which is a complex disease, NASH and NAFLD, is going to require a combination therapy or a combination treatment. Again, we want to use those drugs like GLP-1s, TZDs, which have been studied in clinical trial and shown to improve steatohepatitis and also have cardiovascular benefit. Again, I think I want to emphasize again the goal of weight loss that you want to achieve in these patients, and also the fact that when you use these combination treatments with the GLP-1s, SGLT2s, and pioglitazone, typically the end result is going to be weight loss and not weight gain. So the future that I see for NASH treatments is perhaps similar to what we do with diabetes today. It's going to be a multidisciplinary approach, and it's going to be a combination treatment. And that combination treatment doesn't exclude, perhaps in the future, even digital, tools to help the patient's guide and to improve compliance to the available treatments.